All right, thank you so much. And good morning, everyone. Thanks for having us. Excited to talk a little bit about our group's work on operative performance analytics. Specifically this morning, I'm going to talk about the surgical learning curve. Here we go. So disclosure-wise, I personally have nothing to disclose. The remainder of our lab's disclosures are listed here. So just to hash out a little bit about what I mean about operative performance analytics, ideally we would like to model whatever it is that is a quality surgery in a simple way. And the process should correspond to the results. The results obviously in medicine generally, or whatever the best patient outcomes are. But in general, the long-term outcomes aren't immediately available for learning curve analysis. What's done frequently is using operative time as a surrogate. So methodologically here, we looked at robotic sleeve gastrectomies. This is a video-based analysis using crowdsourced gear scores to assess technical skill. We compared them amongst high-performance surgeons at our health system, as well as for how they performed over time. I'm trying to answer the question if technical skill corresponds to the surgical learning curve. So this is a box and whisker plots of both the overall gear scores on the left between those four surgeons and the operative times on the right. You can see that the gear scores tend to cluster a little bit, as is reflected as as is reflected by the statistics that are given above, and the operative times tend to differentiate a little bit better between the surgeons. These are the tabulated results of the ANOVA parameters. And see, most importantly, drawing your attention to the operative time has the largest effect size, meaning that the difference between surgeons was the greatest here and contributed most to the variability therein. So this is the linear regression analysis for the surgeons corresponding to the gear scores as well as the subcomponents and operative time. So a few of the important trends. So one thing of interest is that the subcomponent score of force sensitivity actually increased in time for all the surgeons across the study period, which was 2 years. And then operative time, unadjusted here, did not improve for any surgeon. So where is the learning curve that I mentioned? We thought that the learning curve as seen in operative time was confounded by phase variability, and some surgeons include hiatal hernia repair, some surgeons don't. So we manually segmented the videos for gastrocolic ligament dissection, stapling and oversewing, and found that comparing a novice surgeon A and a much more experienced surgeon, surgeon C, that there was indeed a learning curve here after controlling for that variability. And you can see that the novice surgeon tends to trend down towards where the more experienced surgeon is, and that reached statistical significance. So just to conclude, there were some small technical differences between surgeons for robotic sleeve gastrectomy. Operative time showed higher variability and does seem to correspond to the surgical learning curve when you look at that novice surgeon. But we don't think that technical skill can explain most of that variability or that learning curve. We need to do a lot more work to define what is the best surrogate metric to use for surgical learning curve analysis, though.